Cancer was actually for adults, very old people. Yes, I never knew, and I had never heard of a child having cancer before, never in my life, until my child was diagnosed with cancer.
Treatment is not on national health insurance, and it should be, because we are doing these children a great disservice.
Support from government.
The government should come in, and if they can add childhood cancer in these kidney problems to the national health insurance, so that at least it can take care of whatever expenses.
Cancer is a disease due to an overgrowth of cells in any part of the body. Yes. Normally cells do multiply, but we have ways that the body checks so that they don't grow out of control. But in cancer, the cells are growing out of control, and then they're able to spread to other parts of the body to disturb the normal function of the body. And this can cause a lot of ill health, and if not treated, can also lead to death.
One major difference is in the type of cells that make up these cancers. So those in the children are made up of more immature cells, whereas those in the adults are made up of more mature kind of cells. Yeah.
One thing that separates it from adult cancer is the percentage survival rates. In children have a higher survival rate of cancers than in adults, comparatively.
So the difference is mainly the cells, the type of cells, which are more immature cells in childhood cancers, whereas the adult cancers are usually those of what we call carcinomas. The commonest cancers are the lymphomas, that's the cancers of certain glands of the body, and then leukemias are also common, then the eye cancer, retinoblastoma, and then kidney cancer, which is Wilms tumor, and then you can get the bone cancers and liver cancers.
Children, we can't specify what caused it. Radiation has been implicated.
There have been theories that say that some of the factors that actually operate to cause these cancers may have been occurring even before the child was born. So there are more of risk factors and things that will put the child at a higher risk of getting. But even that, for most of the children, you won't find these things.
It's very difficult for us really for most of the childhood cancers, what causes childhood cancer. But we do know that things like excessive radiation. So that's why we say pregnant women shouldn't be exposed to X-rays. And then also there are some viruses which can predispose the children to cancer, and repeated malaria infection. So we know that one of the very common cancers, Burkitt lymphoma, has an association with a virus, EB virus, and malaria. Fortunately, nowadays we don't see Burkitt lymphoma as often as we used to in the past. Maybe that might be due to better malaria control, we don't know. And we know that excessive exposure to pesticides, you know what they use on farms and those sorts of things. That's why people have to be very careful and use protection. Sometimes some drugs can predispose to cancers. They are complex drugs. They're not drugs that you can buy off the counter, but some complex drugs as well. And then other viruses like hepatitis virus can lead to liver cancer, but that liver cancer occurs in older people. We have liver cancer in children, but that one is more due to the immature growth of the cells. Yes, not due to the virus. But for the most part, we don't know the cause. And it's only about 5 to 10% of childhood cancers that you can say there's a hereditary cause, genetic cause, only 5 to 10%.
Most of the early signs mimic a lot of common childhood ailments. So usually when you see those things, the first thing that will come to your mind might not be cancer. We have an acronym, SILOAN, which we use.
So the first, which is S, says to seek help for persistent symptoms. So if there's been any symptom whatsoever that's going on with your child that has been persistent for the week, 2 weeks, you've been doing whatever, and it's still there, you have to seek further help, a second opinion.
You know, when you take our eye, there's the white part, there's the black part, and then inside the black part, there's a smaller circle. So when you see that there's a white spot in that smaller circle in the eye, which we call the pupil, it could be an early sign of one type of cancer in children called retinoblastoma. That's cancer of the eye that affects the children. And any other thing that might be suggesting to you that the child cannot see. A child who used to previously see well is now bumping into things. The child walks in, you realize that the child is probably not seeing well, or you try to let the child follow the direction of your fingers, but the child is not able to do it. Anything that will suggest to you that the child is not seeing well could be an early sign of a cancer.
We also have lumps all over the body, so lumps around the neck, lumps around the armpits, or you notice that the abdomen is growing bigger and bigger, you're not sure what it is. Maybe you touch the tummy and then you feel some sort of a mass in the tummy. Those could be early signs of cancers.
Then U stands for unexplained symptoms. So anything that you can't explain, like this child is suddenly losing weight, this child suddenly having bleeding gums, or any funny thing that you can't explain, you need to, or is suddenly very tired, you need to report to the hospital.
Another thing is when the child is always complaining of aches here and there, or when the child easily breaks a bone. So maybe the child just falls from, just say, maybe from this chair, falls onto the ground. The impact isn't that great that you'd expect it to cause a fracture, but then it causes a fracture anyway. So something like that should draw your attention to the fact that maybe something is wrong. It could be an early sign of a cancer.
And the last one is N, which is neurological, which stands for things that have to do with the brain and the spinal cord. So things like persistent headaches. Children will rarely say they have a headache. So if a child has headaches or suddenly starts to have convulsions, or just a change in the way the child walks, or just a change in the behavior of the child, all these can be early warning signs of childhood cancer.
At first, now of it, so you don't go hospital. I'm so much in Tiabana say later, no, you say, ne, by say, ben a rape to honor. And I didn't go hospital.
Vivat was a bubbly girl. We never saw any serious symptoms showing on her. She was just one healthy girl running around until she fell at school, and then we realized a swell in her abdomen. We ran a scan, and then we found out that there was a tumor actually growing in there that we were not aware of. We didn't actually know that there was something going on in there until she fell and realized that the tumor got distressed. So it was bleeding in there, causing that swell. So a biopsy was done on her, and then it was confirmed that it was cancer. Yes.
You see, there aren't any clear symptoms of it, especially with the leukemias. There aren't, because you're not going to get a boil, you're not going to get this, you're not going to get that. You just have chills, you're going to have headaches, you're going to have like fever, like malaria. That's how it comes.
She complained about pain in her left lower tummy, and she complained a lot, so I took her to the nearest clinic in our vicinity.
So my sister saw that there was a swelling under her left side. So like she complained like 4 times.
Oh man, I'm a baby. It's not no sheshe. I am my man and told one who say, near father.
I went to school then because of pencil, and my friend used his hands to beat my kidney. I feel pains.
There is always a red herring where they will say that, oh, I was playing and my friend pushed me at school or whatever. But if it was the friend who pushed him at school, you've used ointments for 3 days, the pain should go away, but it's still there, so that's a problem. You need to go to the hospital.
In our society, most people believe that it's witchcraft, or someone gave it to someone, or maybe the child picked it from somewhere, or the mother did something bad during the pregnancy that could make the child have cancer.
Or they may have the misconception that if a child gets cancer, the child will die. That's not true. With the right treatment, given early enough, the child has over 80% chance of cure. Then they may also think that cancer is infectious. It is not infectious. This is the time that the child needs all your love and to have family around to support them. It is not infectious. And they may think that, oh, with the treatment, the child may become infertile, not be able to have children in future. That is not really true. It all depends on where the cancer was, what treatment was, and what treatment was given would determine that. But we have a lot of children. They are not even children now, they're adults. They're married, they have children.
I knew of adults who have this cancer, especially our mummies who have breast cancer. For kids to have cancer, I was so much alarmed and very disturbed.
Until I came into the profession, I didn't think children were affected with cancer. Kolebu is my first time experience caring for children with cancer.
Those are some of the common myths, and then one of the most common myths is that those children would die anyway. Unfortunately, this is what a lot of people have at the back of their minds.
Currently, we don't have a national population-based cancer registry. So we sort of project what global pattern is like to come out with estimates of what we would expect. So we would expect about, using our population of about 30 million, we would expect about 1,200 cases of childhood cancer a year. But the two main centers in Accra and Kumasi see only about maximum of about 400 cases a year. So that means we see only about a third of the cases. What happens to the remaining 2/3? I'm sure you all know what the consequences, unfortunately, of cancer that isn't treated would be. Yeah, so we've got a long way to go in terms of raising awareness, both amongst the general population and amongst our own health workers for early detection and early referral to the appropriate centers.
Over 80% of childhood cancers can be cured if treated early.
It could be better. One of the challenges we are facing is a lot of the cases present late, where the cancer has spread. It starts in one organ, maybe the kidney, and by the time the child comes, it's already spread sometimes all the way into the chest. Sometimes you have even spread through the veins to the heart and everything. You have it spread all over to the bone marrow, sometimes to the head. And so we get a lot of cases coming in, but unfortunately they come in quite late. But for those that we say we'll be able to treat that are not late, so for the late cases, we can only offer them what we call palliative care, that is pain control and controlling other symptoms. So unfortunately, the inevitable would happen. But for those that are treatable, I would say like the kidney cancers, we get about 70% long-term cure for the kidney cancers, okay? The eye cancers, parents, unfortunately, when they come in, because they're told the eye, one eye would have to be removed, and they'll put an artificial eye there, quite often they leave and don't come back. And by the time they come, the eye is bulging and it's late, and sometimes it's even spread into the brain. But for those that come early, that just need the eye to be removed, and they put in an artificial eye. We've got a lot of children with artificial eyes, but unless you look closely, you wouldn't be able to tell that it's artificial. For those that come early and have an artificial eye, with that one, the cure rate would be over 70% with us. But in the advanced countries, it would be over 90%, because they would even detect it when the child is a baby. Yes, unfortunately, we do get some babies going to health centers or going to child welfare clinics and telling the staff there, not the baby, but the mother would tell the staff there that when they're going for weighing, that, oh, I've seen a shiny white spot in the eye. Unfortunately, the health workers might tell them, oh, that's how the child was born, and it's nothing. So the parents go back falsely reassured to come back when the child is about a year of age and it has started bulging out. But we have babies, usually that one presents soon after birth. Within a few weeks of birth, you'll notice a shiny white spot in the eye. And with that, treatment can be given and the child will be saved, alive, with 90 to 95% chance of long-term cure.
I'm saying it now that childhood cancer, they are very curable and they can live a normal life after treatment.
We have 3 main modalities of treatment, which is the chemotherapy, we have surgery, and we have radiotherapy. Depending on the type of cancer, you may or may not need all three of them. So chemotherapy is basically using drugs, and these medications are given through various routes. Some are taken orally, some are passed through the vein and given various methods. Surgery is simply operation to take out whatever affected part it is. And then radiotherapy is using a sort of stronger form of X-ray to sort of focus and burn off the tumor. Then in addition to this, we also have the supportive part of the care, where we treat infections with antibiotics, we give blood if they need blood, nutritional support.
We don't tend to give radiotherapy that often to children because their cancers respond most of the time to chemotherapy and surgery. So depending, some advanced cases of kidney cancer, you have to give radiotherapy. But brain tumors, unfortunately, brain tumors tend not to present early because we need to do a brain scan. A child complains of headache, give paracetamol, this. By the time they come, it's even they do the scan, it's already grown so huge that it makes treatment difficult. But childhood brain tumors also, after surgery, quite often they would need radiotherapy for that.
When it comes to childhood cancers, we need psychotherapists, we need a social worker, we need a play therapist, we do need a dietitian because with chemotherapy or radiation, it gives you this weird taste in your mouth. They are not able to eat. Sometimes they come with oral ulcers. The drug itself makes them so weak. So our dietitians come in, help us prepare nutritious meals, try and combine some of the local foods that are very nutritious, and then we administer them to these children to help with their weight gain.
When these children are on treatment, you realize that the effects of the chemo nutritionally affect the child in terms of the taste buds. So probably during chemo or after chemo, the children might not be able to tolerate some kinds of food. So the dietitian is involved in planning the meal of the diet. The child is able to tolerate most of the foods. Usually we try liquid foods, so it's just like you giving the child a balanced diet, but this time in a liquid form, because those ones are a little bit tolerable compared to the solid foods.
We have the medical aspect of it, and we also have phantom pains. And because the child has been going through this pain for some time, the child will become conditioned. So even when the gravity of the pain has come down, it is likely that the child will interpret those sensations as pain. And that is where the psychologist will come in. And that yes, the sensation will come, but he or she should think, will not really focus and pay so much attention to the pain. But then we try to give them diversional therapy. And they should focus on certain things so that when you just look in the children's ward, you realize that there are balloons all over the place. The place has been painted with some drawings and all that. And all these things are diversional therapy. And it's a psychological concept. And they are there. They'll focus on those things because children like seeing things. And all these things are things that will help so that the pain that they are going through, they can be able to cope with it. Yeah, so, and these are some of the roles of the psychologist in managing children who go through terminal illness like cancer.
The role of physiotherapists in managing childhood cancer will obviously has to do with if there is any loss of function or disability, or if there is also pain. So we have two main areas when it comes to our role. Is first of all, if there is loss of if there is some kind of disability or some kind of loss of function, we help them to regain their function. And also in cases where we can use non-pharmacological methods of helping them to cope with pain, those areas the physiotherapist has a role in the management of cancer.
Access to the treatment facility is a huge problem for a lot of patients. So right now we have only 2 comprehensive childhood cancer centers in Ghana, which is in Komfanoche in Kumasi and Kolebu in Accra. We also have other shared care centers that are able to offer some level of treatments, like in Tamale, in Cape Coast, in Agogo.
So we commuted from Cape Coast to Kolebu. Every time she needed medical attention with respect to her cancer, and every time she needed treatment or blood transfusion, anything, we had to move from Cape Coast to Kolebu for such treatment. And in Kolebu, if you're on admission, then fine, you will sleep in the hospital. But if you are just taking chemotherapy, that is going and then coming back for the daycare services, it meant we had to book a hotel and sleep in for the period of days that we will spend in Accra. Yes. Then after we come back to Cape Coast.
Every Monday, if you have fascinating, if you have fascinating, 4:00 a.m. Now you have 8:30. Yeah.
Now you can imagine that someone has to leave Elubu to Kolebu for treatment. That to that person, healthcare is not accessible.
Then when it comes to the financial aspect of it, it was a big drain on us because she had a single kidney from birth. So for her treatment and for her diagnosis and everything, we had to speed up things. So the normal route of using the public services, of going to queue for about a week or 2 before you can get an MRI done in Kolebu, we had to use the private places so that in a day or 2 we can get the result and quickly know what was going on with her. And we were not getting financial support from anybody. It was just the family that we did it on our own. So it was quite stressful and a big drain on us.
At times I'll be in Kolebu going to buy a drug, and you go there, when you call the price, it's like you are stranded. You need to top it up. So at times I have to call on a couple of people, call my wife, then they give me something to top it up through Momo before you're able to purchase that. And instantly the child needs that drug to be administered. And if you don't get it, looking at it, it's very, very stressful. A lot has gone in. I don't have receipts here. I have showed you a lot of receipts. It's very, very expensive. Very expensive.
Cape Coast, fortunately, is now developing into a center, and we have some treatment in also for some of the cancers in at Tamale, but they communicate with us, so we call them shared care centers. So currently, Cape Coast is a shared care center, Tamale is a shared care center. Then there are other shared care centers like Techiman, and then Agogo is also another small center. So, but you just imagine patients, children right up north, you know, sometimes because it's not everything that they can manage in Tamale, so they have to come all the way down to Accra, or right from all the way western or eastern Volta region, coming all the way down to Accra. This is a big challenge. So access, geographical access, and transportation costs, and parents having to leave their farms or whatever job they're doing, you know, having to come here. Finding accommodation is another issue, you know, and then looking after the rest of the family they may have left behind. So there are a lot of social issues and cost issues.
Would want to say that there are only 5 pediatric oncologists in the whole of Ghana. So you can imagine with a population of about 30 million, of which 70% are mostly children, you can imagine what we are dealing with.
Cost. Apart from access, once you've accessed the center, it's the cost of treatment. I would say children have not been treated fairly at all. And for years, we've said so much and been to the policymakers all over about childhood cancer, and it's being absorbed under the National Health Insurance Scheme. I know some aspects of breast cancer and cervical cancer are on the health insurance. So why should a child who, when cured of cancer, has at least 50 to 60 years potentially of productive life to give back to society, why should they be denied this? And why should a child with maybe tuberculosis or pneumonia be able to access treatment and a child with cancer can't? And let's say an adult with breast cancer needs a drug, let's say doxorubicin. The adult can access that on health insurance, doxorubicin. The same doxorubicin, which is life-saving in a little one, in a baby or a young child, at a fraction of the cost, the child will be denied.
Country as a whole, if we are losing our future leaders, as we call them, to childhood cancers, then we know that in future the workforce is going to be reducing.